Okay. Can you see my screen now? Can you see my screen now?
It's okay, everything. Go ahead.
Okay. So I'm going to present a case of percutaneous closure of a left ventricular pseudoaneurysm. Our patient is an 88-year-old male who presented with dyspnea on exertion and fatigue. He had a past medical history of inferolateral wall ST elevation MI 2 years prior to presentation, which was complicated with syncope and was treated with primary PCI of the right coronary artery. At the same time, he had moderate narrowings in the LAD and the circumflex arteries. He had chronic anemia and he was a former smoker. At the time of his presentation to us, he was thin, frail, with good vitals and a hollow systolic murmur. This is his transthoracic echo. We can obviously see the LV, the LA, the thin inferolateral akinetic wall, and this cavity behind the inferolateral wall that actually communicates with the LV. And you can see the flow towards and from this left ventricular pseudoaneurysm, which is basically a contained rupture that happened at the time of his initial myocardial infarction. This is his updated left ventriculography in RAO and LAO projections. You can see that this is a large pseudoaneurysm, and one can imagine how this pseudoaneurysm steals blood from the LV and decreases the effective cardiac output of the patient. This is a CT image, again the akinetic inferolateral wall with the neck of the pseudoaneurysm that measures at about 14 millimeters and connects the LV to this cavity. Left ventricular pseudoaneurysms, unlike true aneurysms of the LV, grow and prone to rupture. So closure is, usually surgical closure is recommended. Moreover, our patient had the symptoms of heart failure, and we discussed surgical options with him, but we considered his request reasonable since he was 88 years of age, thin and frail, and he requested that if we can do something for him to avoid surgery. So we sat together and we made an interventional therapeutic plan for him. We measured the neck of the pseudoaneurysm at 14 millimeters. We're a little concerned about the proximity of the mitral subvalvular apparatus, and we ended up choosing an Amplacer muscular VSD 16 millimeters of waist device for closing. We decided to use general anesthesia for TE guidance. We obtained bifemoral arterial access, and we used an 8 French 90 centimeters destination sheath for delivery of the device. This is the device that we used, the Amplacer muscular VSD device, that has a waist of 16 millimeters diameter, and the discs that it has are not that large, so we're hoping that this will not interfere with the mitral subvalvular apparatus. These are procedural TE pictures, and again, the anterior wall, inferior wall, the akinetic inferior wall with the neck of the pseudoaneurysm that is basically the free wall rupture. This is transgastric view demonstrating again the same thing, the neck and the pseudoaneurysm. And these are our procedural steps. From the left femoral, we inserted a pigtail in the LV, and from the right femoral, we obtained access to the pseudoaneurysm cavity with just a diagnostic JR4. We inserted a hand-shaped Amplacer super stiff guide wire in the pseudoaneurysm, and we exchanged the JR4 for the destination sheath, through which we inserted the device in the pseudoaneurysm, and we positioned it at the neck of the pseudoaneurysm, released it, and with a very good result, as you will see. These are more pictures from the procedural TEE. You see the device straddling the neck of the pseudoaneurysm. And again, the TEE pre and post, there was trivial residual flow. And these are some TEE pre and post frames that you can see the device here sitting well with trivial residual flow. The patient did well. He went home next morning. He had progressive clinical improvements, and 18 months after the procedure, he's doing well. These are some of his transthoracic pictures at 1 year. You can see now the device sitting well in the inferolateral wall, and the left ventricular pseudoaneurysm has been thrombosed entirely. The mitral apparatus is intact, and there is obviously no flow in the pseudoaneurysm. In summary, we presented a case of left ventricular pseudoaneurysm, which is a contained free wall rupture from inferior wall MI. It's a rare complication of MIs. Only 0.2% of MIs lead to pseudoaneurysm, but it's potentially lethal. Myocardial infarction is the most common cause of left ventricular pseudoaneurysm. 55% of pseudoaneurysms are caused from MI, 33% from surgery, 7% from trauma, and less commonly from infection. As it was mentioned, the pseudoaneurysms, unlike true aneurysms, tend to grow, rupture, and if they're treated medically, the mortality is very high, reaching 45 to 50%. That's why surgical treatment is recommended. However, surgical procedures are reported to have high mortality too, 10 to 30%, much lower than the medical treatment, but still high. And percutaneous closure seems to be feasible. Of course, there are no randomized clinical trials in such a rare case. There are only case reports and case series of successful and feasible percutaneous closure. There is no standardized approach, no standardized device for this indication. That's why we need individualized approach, pre-procedural planning, very careful step by step, and teamwork. Thank you very much for your attention.
Great case, difficult. How many days after the infarction did you recognize this complication?
He came to us 2 years after his infarction.
2 years after, and
Yeah.
was still alive. 2 years.
He was.
Yeah, unbelievable. Dr. Hamilos, any comments?
It's an amazing case, very rare. Never seen a pseudoaneurysm patient living 2 years after the infarction. Our experience is that those patients, they don't do well in the first case, the days after the infarction. So it was a lucky patient, and it was also lucky to have you as a doctor that you treated so nicely this difficult task. Congratulations. Nothing more to say.
Yes, congratulations again, and we are moving to the last but not least presentation.